Okay, welcome everybody. It's Euro 2020 and we're in London at Wembley. It's kind of balmy and wet outside. No, it's not, but good luck to England. I hope 1966 comes back again. Yeah, but thank you everybody. This is SARC 2021 and we are not at Wembley. But thank you all for coming here and having a very good session with us on perioperative medicine and blood management. And we have a great lineup of speakers today. I'll introduce each one before their talk. And let's go right into the session and discuss about how we can do peri-op blood management better. We know that when bleeding occurs, it is up to the surgeon or the interventionalist to stop the bleeding. But for us, it's our job to make the blood clot. So let me first say a few words about Fibriga. So you can bring on the slides, please. So Fibriga, the main thing to note is that now Fibriga has got HSA approval for acquired fibrinogen deficiency. So for the longest time, any one of us who has been using Fibriga was using it actually sort of off-label because up to now it was only used or approved for congenital fibrinogen deficiency. So now, very kosher, we're all allowed to use it. HSA approved for acquired fibrinogen deficiency. Next slide, please. So what makes Fibriga good? To me, there are a lot of things you see there, but it's got factor 13, which is very important for stabilizing the clot, which other fibrinogen concentrates do not have. It's high quality and pure, and it's stable for 24 hours post-reconstitution, so that even if you don't use it right now, you can still keep it for the next dose, inactivated for safety. But you know what's most important to me is that it's ready to use off the shelf. It is there. You don't have to argue with a BTS MO for fibrinogen concentrate or fibrinogen, not like you have to do with cryo. Next slide, please. So this is the product, and we're going to show you in a video how to dilute it, especially with this very special widget that you can use. So just have a look at how to reconstitute it, because this is a common question. So for any of you who have not used it before, this thing which you're using, this little widget as you would call it, really will make your life easier, okay? And I would encourage you to use this instead of what we are used to, which is getting a syringe out, drawing out the diluent and shoving it in and shaking it, because this is much, much faster, I'll tell you. It really is. And as you can see, it's really easy to use. You put the spike in both ends, plunge it together, take out the safety catch, and Bob's your uncle. Look at the counter on the side. You know, it really takes only a few seconds to get this done. So often some people may say it's really hard to dilute, you get lots of bubbles and all that, but I would really encourage you then to use this little device, okay, to get it reconstituted. So in less than 2 minutes, you've got Fibriga ready to inject into the patient, as opposed to waiting 2 to 3 hours for the cryo to be to be thawed and brought to you. So yeah, next slide. So approved all around the world for acquired fibrinogen deficiency, including recently in Singapore as well. Next slide. So this is some examples of the clinical settings which we get acquired fibrinogen deficiency, and we will be going through some of these with you in the case presentations as well. Next slide. Okay, so We are going to introduce Professor Klaus Gollinger. So for any one of you who has been interested in coagulation medicine, Klaus does not need any introduction. To me, he is the father of ROTEM, the father of the use of PCCs and Vibriga, and he truly is someone who crossed the from clinical management into research and back to clinical again, and no better man to tell us about firstly the basics of ROTEM, and also to take us through some of the recent trials involving Octaplex and Vibriga. Thank you, Professor Gollinger.
Yeah, thanks, Jonathan, for the kind introduction. I hope you can see my slide. So in the first talk, we will discuss ROTEM basics to give you an idea how ROTEM is working and what's the basic interpretation of ROTEM. You heard already about my background. So I worked 26 years as a senior consultant for anesthesiology and intensive care. And what we have in Germany, hemostasiology, it's people who taking care for acquired bleeding at the University Hospital of Essen. And most important for my conflict of interest, in 2012, I moved to the dark side of power. And since then, I'm the medical director of TEM Innovations, the ROTEM company. So as Einstein said, if I had an hour to solve a problem and my life depend on it, I would use the first 55 minutes determining the proper questions to ask. But okay, we have only 15 minutes available, so I have to speed up a little bit. And as mentioned before by Jonathan, of course, sometimes we have to decide, why does my patient bleed? And it can be, as on the left picture, a surgical bleeding. And then, of course, we need sutures, clips, or intervention. And it can be a coagulopathic bleeding, as on the right side, which we call a blood on floor syndrome. And then usually it's even a combination of both surgical and coagulopathic bleeding. So we have closely together to stop the bleeding. But the question is how to fix it. And historically, well, I just saw this is not already in the presentation mode. Sorry for that. So how to fix it? And the historical option is just refill, which means if the patient is bleeding, we just replace whole blood or blood components in a specific ratio. And the other option would be to close the holes. And what we learned, of course, is that transfusion is not the adequate answer just to bleeding. It's to stop the bleed. And again, the two options are if we just refill, activate our massive transfusion protocol and transfuse red blood cells, fresh frozen plasma, and platelets in a certain ratio as quick as possible, or just to open the fridge and give everything which is inside. And option two is to activate a massive hemorrhage protocol, which includes usually a ROTEM analysis. And since not every anesthesiologist and intensivist can be an hemostasis expert, we are seeing that it's very helpful to implement quite simple transfusion protocols to guide the clinician through the analysis and help to do the right decision. So that brings us to the question, why are we performing viscoelastic testing? And here we have to understand a ROTEM-guided bleeding management as an essential part of patient blood management, in particular of the second pillar, which is minimize bleeding and blood loss. But again, it's not about blood transfusion, it's about patient safety. And already Hippocrates, 2,500 years ago, said that, of course, as physicians, we like to cure, but maybe more important it is to not to add additional harm. And it's quite interesting that in the journal Hippocratia 3 years ago, there was an article talking about the association between transfusion prescribed in the traditional way and mortality in cardiac surgery. And they observed, like a lot of other authors, a clear relationship between the volume of transfusion and observed mortality. And this is for all the allogenic blood products. So we see here that platelet transfusion if we have to give more than 10 single units, which would be a 2 pooled platelet concentrate, we see that mortality went up from 8.5 to 24.5%. For fresh frozen plasma, this is already evident if we give more than 5 units, and then it's increased from 6 to 27.4%. So it has the highest increase for mortality. And for red blood cells, it's quite similar. It went up from 4.5% below 5 units to 23.9% if we give more than 5 units. And it's also by combining this product. And you see again that the highest increase in mortality is if we give red blood cells and fresh frozen plasma together more than 10 units. And then it increased the mortality from 4.7 to 26.7%. So we are talking about a more than 5-fold increase in mortality. And even if we look at the neonatal and infant patient population, here we are not looking at mortality, here we're looking at thromboembolic complications. But we know this is also not good for our patients. You see that in particular, if we use a lot of different products together because we don't know why the patient is bleeding, the incidence of thrombosis went up from 0% to 30% if we combine platelets, cryo, and recombinant factor 7A. Anyway, in this study where ROTEM was not used to guide therapy, it was just an observational study, it was clear when you measure a ROTEM at admission to the ICU, the XTEM with a cutoff of 69 millimeters and the FIBTEM with a cutoff of 22 millimeters was very predictive for thromboembolic complication. That's nearly the same cutoff we have also saw in adults, where it's for XTEM 68 and for FIBTEM 24. So the authors concluded, and the study was done at Harvard University, that there is a clear association between transfusion of blood products in neonates and young infants and the incidence of thrombotic complications. And this happens in particular if no viscoelastic testing is used during surgery, and then very frequently cryoprecipitate, platelets, or recombinant factor 7A or plasma is given just based on gut feeling, and it might be given even without a coagulopathy, just in surgical bleeding, or if there's a coagulopathy, it's quite often overtreated because even dosing in these very small patients is not easy. So on the other hand, viscoelastic testing, even if it's not used for guiding therapy, it's very predictive for thromboembolic complications. And we learned this also in the last 1.5 years in the field of COVID-19. So what we are actually moving is from a water can approach, so one fits all, to precision medicine, which means we measure, identify the reason for bleeding, and then very specifically at best with factor concentrates, we fix this problem. So for this, we have to understand the parameters. We can just do a short introduction, which means we are looking at the coagulation time, CT. This tells us something about missing enzymatic factors or anticoagulants. Then we look at the amplitude. Historically, we use a maximum clot firmness, but this takes about 25 to 30 minutes. And therefore, 10 years ago, we developed and validated the amplitude 5 or 10 minutes after clotting time. That means that within about 8 to 12 minutes, we can do the whole interpretation, which means this reflects the contribution of platelets and fibrinogen to the clot firmness. And we can see if the clot is stable over the time or is any thrombolytic issue. We also use test combinations in ROTEM. So a typical combination is, for example, to combine XTEM and FIBTEM. XTEM has calcium chloride inside, which is used for recalcification, activators, tissue factor, and it has also polybrain inside, which is like protamine, a heparin inhibitor, which means we can even measure on cardiopulmonary bypass by eliminating the heparin effect. And then if we see that clot firmus, so A5 or A10, is reduced in XTEM, and the question is that due to a low fibrinogen or a platelet issue, we can use the FibTEM to answer this question, because in this test we knock out the platelets by cytochromazine D. So if the fibrin clot is fine, it must be an issue with the platelets, and if the FibTEM is reduced too, we know that the main issue is a fibrin polymerization issue, which we can, for example, fix with fibrinogen concentrate or cryoprecipitate. There's another specific test, the UPTEM, which can be used if you're not sure if the patient will benefit from an antifibrolytic drug, to simulate this. And on the right side, we have the intrinsically activated test like INTEM and HEPTEM. And here we usually compare the clotting times or coagulation times. So if it's prolonged in INTEM but normalized in HEPTEM, this proves that this is based on a heparin effect. If both are prolonged, it can be a factor deficiency or another inhibitor of the intrinsic or common pathway, which can be a protamine overdose or can also be a DOAC. Then the XTEM would be prolonged too. And we are just bringing back a test which we had already 10 years ago, but we changed the composition. This is an eccrine-based test, which then can even discriminate between direct thrombin inhibitors and direct 10A inhibitors in case of DOAC treatment. So we just go through a typical algorithm. Here's a trauma algorithm. It's kept quite simple as possible. And on the left side, you have light of flight checklist, step by step, the results from the ROTEM analysis. So also the sequence matters. And on the right side is the corresponding intervention. And all algorithm starts with a clinical situation. So that means we only treat bleeding patients. If we answer the question, if there is diffuse bleeding and we have to consider an intervention, is answered with yes. If it's answered with no, the algorithm stops. And the right box just should consider that, of course, we not treat the ROTEM in isolation. We also look, of course, at blood gas analysis with pH, base excess, calcium level, and also, of course, hemoglobin level. And we can use ISS or TESH score for a clinical assessment. If tranexamic acid was not given blindly already in the first 3 hours after injury, we can use early clot firmness parameters, which predict quite nicely, even late lysis, or we can use the classically parameters. But again, this doesn't mean that we should always wait for the ROTEM results. In the first 3 hours after injury or delivery, we can give tranexamic acid blindly. The next box is to look at clot firmness. And again, here we are using the amplitude after 5 minutes in XTEM and FibTEM. And if both are below a certain cutoff specific for trauma-induced coagulopathy, then the intervention would be to increase the fibrinogen level by fibrinogen concentrate or cryoprecipitate. And we can use the results also for an adequate calculation, which we will discuss in the next presentation. If the clot firmness after 5 minutes in XTEM is reduced, but it's fine in FibTEM, then we have to consider platelet transfusion. And more, we also look at platelet functionality, because this can be changed in trauma or in other settings, even without antiplatelet drugs. And then we look at thrombin generation at the extrinsic and intrinsic pathway. And finally, after each intervention, we wait about 10 to 15 minutes if the intervention works, and then we have to reassess clinically as well if there's ongoing bleeding with a new blood sample, run the protocol again. So the concept of a ROTEM-guided patient blood management is to administer just the right hemostatic drug in the right dose at the right time and the right sequence. And we want to avoid any inappropriate blood transfusion, since we know that this can also be associated with harm. So we have to understand ROTEM algorithms as not to do algorithms. So that means we use a high negative predictive value of ROTEM tests to exclude step-by-step reasons for bleeding. And if we run through the algorithm and we don't find any coagulopathy, that usually means that is a surgical bleeding, or, for example, in postmortem hemorrhage, just a uterus atony. And these patients need another measure to stop bleeding, and it's not like a coagulopathic bleeding. However, time always matters in severe bleeding, and this has been shown also in the proper trial from the US, not looking at WELLCHEM results, but I think this is a general point that if we can stop bleeding earlier, this is good for our patients. And that has been shown also in the proper study, that every 15 minutes decrease in time to hemostasis was associated with a decrease in 30-day mortality by 3%. This doesn't sound a lot, but as we heard before, for example, the difference in turnaround time between WELLCHEM results and standard lab is already about usually 45 minutes. And also the difference between having Fabriga available and having cryoprecipitate available, this is again 25 to 30 minutes. So overall, we talk about 1 hour delay in diagnostics and treatment, and this is 4 times 3%. So that's a difference in mortality of 12%, which is a lot. And the same applies for acute kidney injury, lung injury, multiple organ failure, sepsis, which is also reduced by 2 to 3% every 15 minutes, and no increase, it's even a 1% decrease in thromboembolic events. And that's the reason also in the European trauma guidelines, as well as in this editorial to a study done by Donat Spahn in Zurich, is that it's very essential to start early in trauma with the first measurement. That means it should be done as soon as possible after patient arrival, because it's important to differentiate between the coagulopathic and non-coagulopathic patients. That this is feasible, in particular also in patients with traumatic brain injury, has been shown here in this interventional trial as a part of the European Center TBI trial about traumatic brain injury, which we did in 5 centers, never used the WELLCHEM before. And by using the WELLCHEM Sigma and training a simple protocol, we were looking at implementation. And you see the time to results after admission could be achieved within 20 to 40 minutes. That is 50 to 100 minutes for standard coagulation tests. Of course, for both, you need a blood sample. So the time from blood sampling to the result was 10 to 20 minutes for WELLCHEM, 40 to 90 minutes for standard lab test. And when we look here at the last line, this is very important for implementing an algorithm and using factor concentrates, because you see that the time between having the WELLCHEM results and therapy is done was in mean 9 minutes. This is only possible by using a clear algorithm and factor concentrates, because using cryo, it's impossible to do this within 9 to 10 minutes. This was a simple protocol, so just clear indication for tranexamic acid, fibrinogen, platelets, and PCC or fresh frozen plasma. And the last one might be the most important one. If we say 4 times no, that means there is no coagulopathic bleeding, which applies for 75% of our severe trauma patients. And what you also see here, there was a quite good agreement or adherence to the protocol between 87.5 and 90%. So if you use a quite simple protocol, then even for a non-hemostasis expert, it's possible to follow this protocol. To show you just some examples, what we see here, this is a normal tamogram, just looking at the XTEM and FIBTEM. And on the left side, we see a typical case with hyperthrombolysis. So here, that's 10, 20, 30 minutes. Within 30 minutes, even the clot is dissolved. And it's even quicker to be seen in the FIBTEM, because the FIBTEM is the most sensitive test for thrombolysis. And this is just the opposite, which we call a fibrolysis shutdown, which means there's less than 3.5% lysis within 60 minutes. Very typical for our COVID-19 patient population who develops a thromboembolic event. Coming to clot firmness management, here again, it's just how it looks when it's normal. And on the left side, we see a reduction in XTEM. So the A5 is dropped down to 24 millimeters. Even for liver transplant, this would be too low. And here the FibTEM with 6 millimeters shows that the main reason for the reduction is a low fibrinogen. So again, this patient will benefit from a fibrinogen replacement. And on the right side, we have also reduction of the XTEM A5 here to 29 millimeters. Could be the same as on the left side. But we see FibTEM is very strong with an A5 of 15 millimeters. So that would even sufficient in postpartum hemorrhage. So here we have a problem of the platelet contribution. So this can be easily discriminated within about 10 minutes by comparing XTEM and FibTEM. Looking at thrombin generation, we have to look a little bit more closely to the curve. And here we use the combination of XTEM and HepTEM. You could also use INTEM, but if we want to eliminate any potential heparin effect, both tests here, XTEM with polybrain and HepTEM with heparinase, doesn't have any influence by heparin. So now on the left side, we see there is a prolongation of the XTEM clotting time to here more than 90 seconds, which usually means that we are down with a vitamin K dependent activity to 20 to 30%, but the HepTEM is still normal. This is just here, depends on the reference ranges you use, but 220 seconds, it's quite fine. So this is typical picture for vitamin K antagonists like warfarin. Prolongation of the XTEM clotting time, but still normal INTEM clotting time. And when we look at the right side, we see a strong prolongation of the XTEM clotting time as well as the INTEM clotting time, or here HepTEM clotting time. And this is typical for a DOAC because here we block the common pathway, and in particular here in this case with dabigatran, where we block factor 2, we have quite significant prolongation of both. In the future, the ECHARIN test will help us for a clear differentiation if this is a direct thrombin or direct 10A inhibitor. Looking at heparin protamine management, again, here usually we use the test combination INTEM and HepTEM. So the test without a heparin inhibitor and with a heparin inhibitor, looking at the intrinsic pathway. On the left side, now we see a significant prolongation of the INTEM clotting time. Here it's even nearly 700 seconds. Still normal HepTEM clotting time. This proves as a residual heparin effect, for example, after giving protamine in cardiac surgery. But in between, we learned that even in severe trauma, in liver transplant, and other severe shock, we can have an endogenous heparin effect. And on the right side, we see a combination where INTEM and HepTEM clotting time is prolonged. This can be in cardiac surgery, a protamine overdose, or it can be a DOAC, or it can be a deficiency of factors from the common pathway. And finally, we have, again, first the normal thermogram, and then we see on the left side a significant hypercoagulability. You see maximum clot firmness in XTEM is 78 millimeters, even in FibTEM 50. So it's also a picture we see often in COVID-19, but here we have also some good news because this is physiologic lysis between 3.5 and 10%. So risk of thrombosis is relatively low despite hypercoagulability. And from the picture, you have really to look closely that here is no reduction in clot firmness over 1 hour. So that means only 1% or a lysis index of 60 minutes or 100%. This is hypercoagulability with fibrolytic shutdown. And this is associated with a very high risk of thrombosis. So in the ROC curve analyze, the area under the curve is 0.92, which means really a high risk. So to summarize, we move actually, as mentioned, to precision medicine. That also means we need specific algorithms for the different settings because the pathophysiology of bleeding is different in cardiovascular than to livers or trauma or obstetrics. We will discuss this in the next presentation a little bit more in detail. And just to summarize this point, I hope I could show you that rotational thromboelastometry is a step forward to safer patient care. And there are 3 essential key points for success. First of all, we need a quick and precise point-of-care diagnostics, which can be provided by WELLCHEM. Second, at best, we have rapid, available, and reproducible therapeutic interventions like factor concentrates, fibrinogen concentrate, and PCC. And third, maybe most important, we need reasonable algorithms with validated triggers and targets to link diagnostic and therapy. And again, this is in line also with the World Healthcare Organization patient safety concept, and actually they promote to implement patient blood management everywhere around the world. And thanks for your attention. So I can move forward directly to the
yes, please, yes, to some updates in the latest trials. Thank you very much, Klaus.
Okay, so after this more or less theoretical background, I picked out some studies from the last years, which has been done in the field of coagulation management. The disclosures are the same, didn't change in the last minutes. Patient blood management, a long time, was just focusing on red blood cell transfusion. But as I showed already also in the first presentation, there are also potential harm by using the so-called yellow blood product, which are plasma and platelets. And even compared to the red blood cell, they are very often just used on gut feeling or maybe surgeon request. But we should do or use these products much more carefully and restrictive, because we know that they can definitely add harm, which is mainly tacho, trali, and immunomodulation. So that means we should also move with these blood products to a goal-directed approach, which I showed you already in the last presentation, means we should use the right product at the right time, in the right patient, and the right indications. And we should limit unnecessary exposure as much as possible. And this is also in line, also there's a lot of change, in particular in the US, because for a long time it was just promoting ratios. But here we see from the 2 years old recommendations from the Society of Cardiovascular Anesthesiologists, that they also move to a goal-directed approach with a clear indication based on WELLCHEM results for heparin reversal, platelet transfusion, fibrinogen replacement, factors, in particular factors from the extrinsic pathway, and fibrolysis management. And this also applies again for our smallest patients, because this is just a randomized study from last year from India, looking at neonates and infants with cyanotic congenital heart disease. The study in 160 patients, and the implementation of a WELLCHEM-based algorithm showed a clear reduction to the exposure to any blood component, and it also reduced the duration of mechanical ventilation by avoiding pulmonary complications, and it's also shortened the time at ICU and of hospital stay. But it's not only important to identify what is the reason for bleeding. And this is a study from London, again a randomized trial in neonates and infants. So you see, even in this field, the evidence is significantly improving. And it's here, one of the authors was even Beverly Hunt. If you asked her 10 years ago, maybe it was not always in favor for viscoelastic testing. But here now is a clear message that if we identify a low fibrinogen, in particular in these very small patients, it's important to calculate the adequate dose, because the range can be between 50 and 200 milligrams per kilogram. But by using the FibTem and the dose calculation, we exactly can adjust even this very critical patient population in the area of 1.5 to 2.5 grams per liter. And I think this is really very important. And it also has been addressed in this international consensus statement from the Hemostasis and Transfusion Scientific Subcommittee of the European Association of Cardiothoracic Anesthesiology.
Sorry, Klaus. Klaus, sorry for a second. We can't see your slides. Sorry.
Oh.
So we're still on the old deck.
Okay, then I just try. Do you see it now?
Nope.
Okay, then maybe I have just to close this one. I just share again. I don't see it. I hope you can see the slides now.
Yeah, we can.
Okay.
Thank you.
I have to go back a little bit. I'm sorry.
Okay.
So coming back to the statement about fibrinogen replacement from EACTA, and it might be a little bit a surprise that they clearly recommend now the assessment of fibrinogen by viscoelastic testing. In contrast, they don't recommend, in particular in cardiovascular surgery, the Claus method anymore, because first of all, the turnaround time is significantly longer. There's a higher variability, and very important, there's an interference with high heparin levels. So, for example, you cannot use the Claus method to measure fibrinogen concentration already before weaning from bypass, which is possible with the FibTem test because it has, again, polybrain as a heparin inhibitor on board. And what they also showed was that fibrinogen concentrate does not increase adverse outcomes if it is guided by viscoelastic testing. So that's a big difference what we showed in the Harvard study in neonates when products were given blindly. Very similar recommendation to use 4-factor PCC in cardiac and non-cardiac surgical patients. So again, in massive bleeding, when we show that there is a prolongation of the clotting time, but fibrinogen is normal because low fibrinogen can also prolong coagulation times, then there is a recommendation to use an initial bolus of 25 units per kilogram. In patients with high thromboembolic risk, for example, in cardiac surgery, we more use a half dose at the beginning and then titrate the effect. The opposite is if we have to really deal with patients with DOACs, we quite often need higher dosages. Again, for monitoring, they clearly say you need a tissue factor activated, factor 7 dependent and heparin insensitive point of care test, which is exactly the XTEM. This is perfect for guiding PCC in the perioperative setting. We are going to a little bit different setting. This is lung transplantation. There have been a lot of work done in the field of cardiac surgery, but this is one of the first studies, at least the first randomized trial in lung transplantation from the Czech Republic in Prague. So in the interim statistical analysis, they had 67 patients in this randomized trial. And what was shown is that the amount of red blood cell transfusion we see here in the right graph is reduced significantly. Fresh frozen plasma is eliminated because it's replaced by a factor concentrate, fibrinogen concentrate or PCC, but also the use of platelets was reduced. So overall, much less allogenic blood products, but a quicker achievement of hemostasis. Of course, this also applies for other settings like liver disease and liver transplantation. An important point is how good the diagnostic device can detect the status of the patient. So here, using viscoelastic testing in patients undergoing liver surgery, it could detect normal situation in 77% of the patients, even hypercoagulability in less than 20%, and hypocoagulability only in a little bit less than 5%. In contrast, conventional coagulation tests like INR or platelet count see normal coagulation only in 1/3 and hypocoagulability in 2/3, and in none of the patients hypercoagulability. So it overestimates the bleeding risk. But what was the clinical situation? No patient experienced postoperative hemorrhage, but 6% experienced postoperative thrombotic events, not at all reflected by conventional coagulation tests. So the conclusion was that global viscoelastic testing provide a more robust assessment of the coagulation status in patients with liver disease undergoing liver surgery. And this is also reflected in liver transplant studies here from Luc Mazicot. He's really a guy with using very low amounts of blood transfusion in Montreal. And 60% of the patient did not receive any red blood cell transfusion, either intra or postoperative, but the FIBTEM was definitely the assay with the strongest association with intraoperative blood loss, and it allowed him also to move away from plasma and to a low volume intervention with fibrinogen concentrate. Why we should not use liberally fresh frozen plasma in patients with liver disease, and here in particular with acute variceal hemorrhage. So in this multi-center trial in 244 patients, fresh frozen plasma transfusion was associated with an increased odds for mortality at 42 days of 9.4. So it's nearly 10-fold increase in mortality. And at the same time, a failure to control bleeding and an increased length of stay at the ICU. And the reason for this is that portal hypertension is the best trigger for more bleeding in this patient population. So the conclusion is that fresh frozen plasma transfusion in acute variceal hemorrhage is independently associated with poor outcome. On the other hand, implementing a concept which includes fast-track liver transplantation with thromboelastometry-guided bleeding management, this was shown to be feasible with a low mortality rate, with a low transfusion rate of only 13% in the operation theater with a mean of 2.4 units of red blood cells. Extubation was possible within 30 minutes in all but 4 patients and good survival rate. So implementing patient blood management and fast-track surgery is feasible even in the setting of liver transplantation. So what does the meta-analysis tell us in patients with cirrhosis? So again, a viscoelastic testing guided protocol reduces intraoperative bleeding as well as fresh frozen plasma and platelet transfusion, independent whether this is a pre-procedural, acute bleeding or transplant setting. And accordingly, all the guidelines from gastroenterology, hepatology, liver transplantation, and critical care clearly recommend viscoelastic testing over measuring iron arm platelets or fibrinogen in critical ill patients with acute liver failure or acute on chronic failure undergoing procedures. And this is one of 6 strong recommendations. In trauma, a similar concept is working. We have to look at thrombolysis if not treated already. But here the game changer is, and that was addressed by several groups, that XTEM is not very sensitive to thrombolysis. However, if we see it, it's associated with a very high incidence of massive transfusion, 60%, and even mortality of 80%. FIBTEM, again, is much more sensitive. So if we see hyperthermia only in FIBTEM, not in XTEM, the massive transfusion and mortality rate is 20%, but it's still twice as higher than patients where we don't see thrombolysis in XTEM and FIBTEM. A lot of validation studies has been done, and this is a tactic study, which was an observational trial before starting the iTactic trial. And you see the algorithm were developed with more than 2,000 trauma patients on ROTEM and 1,000 trauma patients on TAC. There is a difference in performance between FIBTEM and functional fibrinogen because you see there's a much higher platelet noise still there in functional fibrinogen. But of course, the important point are the outcome data from the iTactic study. Here we are looking at 28-day mortality, and it was not a big surprise that in particular the coagulopathic patients, which is only 25%, 75% were non-coagulopathic, but the coagulopathic patient had nearly a 50% reduction in mortality. And the big surprise that was in particular a patient with severe traumatic brain injury had a very good improvement in survival with an odds ratio for 0.28. So that means more than 2/3 improvement. Also, when we look at thromboembolic complications, two randomized trauma studies, iTactic as well as the RETIC trial from Innsbruck, showed this reduction in thromboembolic events in the ROTEM guided group. So in iTactic from 14 to 9%, RETIC from 18 to 8%. Both studies were too small to show a significant difference, but if we take both studies together, we see we still have the thromboembolic complication, and now it's also statistically significant. And this has been shown also in other studies for traumatic brain injury. Here, a study which showed the same adherence to the protocol rate as I showed you in the last presentation. But more important is, of course, a clinical improvement, which showed a reduction of the incidence of progression of hemorrhagic injury from 48 to 30%, and the need for neurosurgical reintervention from 40 to 13%. Also in the military setting, there's an increasing evidence that this even works in field hospitals, here published from Pratt and Andrew Kapp. But this is the biggest study from Afghanistan, 3,300 trauma patients with a significant reduction in mortality with an odds ratio of 0.63 based on viscoelastic testing. And this had also influenced the new recommendation from the US, from the Eastern Association for the Surgery of Trauma, because here also for the first time for trauma patients, just analyzing 6 studies, there is a significant reduction in mortality by 0.75, the risk ratio. However, this is not the only studies which have been done in the trauma field. It's overall 22 studies. The 2 military studies I showed you already, a 3,500 patient, risk ratio for mortality 0.7. It's completely in line with the 20 civilian trauma studies, nearly 5,000 patients with exactly the same risk ratio. And if we take it together, it's 8,500 patients with a risk ratio of 0.71 and a p-value of 0.00118, so highly significant. And this is in line with other meta-analyses, mainly based on cardiac studies, 21 randomized trials, 8,900 participants, looking at the tech studies, not already significant, but with a similar risk ratio as in the trauma studies, 0.71. For ROTEM, it's even 0.48 and already significant. And even if we take TEC and ROTEM together, it's still significant. And the same applies for acute kidney injury, where all the studies showed a clear benefit were based on ROTEM results. And again, this is more than 50% reduction in acute kidney injury, which is important for long-term survival. So to summarize, the preconditions for a clinical effectiveness of goal-directed therapy is, first of all, have viscoelastic testing available. Turnaround time matters. As we said, every 15 minutes delay has an impact on outcome. Of course, education matters, but we still know that not every anesthesiologist and intensivist can be an hemostasis expert. And therefore, I think really the implementation of simple but evidence-based ROTEM protocols are very important to standardize interpretation but personalized therapy. And that also means that we have, of course, also changed our transfusion practice and only use the blood products which definitely can fix the problem. And this is more and more factor concentrates like fibrinogen concentrate and 4-factor PCC. And I hope I could show you that then we have a good chance to improve patients' outcome. And thanks for your attention. And later on, I'm happy to answer questions.
Okay, thank you very much, Professor Gollinger. I would encourage everyone to stay with us because I think Professor Gollinger has gone through the basics of ROTEM, the different tests, has given us a glimpse into the future. Especially, I'm going to be looking out for the tests that will differentiate DOACs and the direct thrombin inhibitors. When in the ROTEM arsenal of tests. And also with that, I think the other very important lesson is that the use of a diagnostic tool, in this case the ROTEM, can give us better outcomes, not in terms of preventing complications, but also reduction of the use of unnecessary blood products. But at the same time, I think, Klaus, your last statement about translating the results of how you use that into an easy to use protocol using the appropriate information, because when we talked about informed decision making, you need good information first, but then you also need to know how to use that information in a timely manner, in the right way. And here's the kicker, right? The right and the appropriate bullets that you can use to fight this battle.
Yeah.
And I think we're going to see in the next two presentations, some case presentations that will take us through perhaps some of the practicalities, and then we look forward to some discussion. Please, everybody in the audience, send in your questions, especially what you face in the field right now, on how we can help some of your queries. So, okay, thank you, Klaus. We'll see you again very soon.
Yeah.
And next up, we have Dr. Louis Ng. Louis is a long-time practitioner of patient blood management. He is the chair of the Blood Transfusion Committee at Changi Hospital, a very experienced blood management expert and anesthesiologist, and has also worked on various trauma initiatives with us as well. So, Louis, please take us through some trauma presentations in regards to patient blood management. Thank you, Louis.
Hi, can everyone hear me? Yeah. So thank you so much for the invite to the talk, and thank you so much for your patience listening to us in such a fine weekend evening while you prepare for Euro 2020 tomorrow. Okay. Dr. Gollinger has obviously given us an extremely detailed talk in a very tight time frame. My job now is just to share some case studies and some case experience to show how we implement how ROTEM and factor concentrates can help in the field of trauma and perioperative coagulation management. So let's go through my contents. I'll be sharing a few cases, of which one will be covering in terms of liver cirrhosis, which Dr. Gollinger did touch about, a patient with multiple trauma, and also a patient with major bleeding from rupture AAA. So let's talk about our first patient. Let's look at our first patient, the cirrhotic patient. I'm sure this is one of the patients we regularly encounter in our clinical practice as anesthetists in any high-risk environment. Coagulopathy in the patients with liver disease is probably one of the most complex to manage. The derangements associated with patients with liver disease is multiple, complex, and interacting and extremely interactive among itself. Based on classical traditional blood tests that we traditionally use, such as INR and FBC and PT, there are many things that we are actually not looking into. So things like thrombocytopenia, we can look into. Things like reduced coagulation factors, we may possibly diagnose with INR and PTE, PDT. But how do we then diagnose platelet dysfunction, reduce anticoagulants such as protein C, S, and antithrombin 3, or the upregulation in factor 7? Or more importantly, how do we know about the fibrinogen level or ongoing fibrinolysis, or whether there's actually any ongoing vitamin K deficiency or even ongoing background sepsis? These are things that is hard to manage or even look into in a patient, in a complex patient coming in for surgery in this background setting of liver cirrhosis or even acute or chronic liver failure, or even in the most extreme sense, patient going for liver transplant. So without further ado, let's quickly look into our patient. We have a 45-year-old male here with a typical history of chronic alcoholic, history of IVDA, which is intravenous drug abuse. It's an ongoing patient with chronic hepatitis C, with Charles B liver cirrhosis, has hypertension, with recent admission with or for variceal bleeding control with ligation, complicated by SBP with a short ICU stay. He was fortunately discharged well, and now he's coming back for elective OGD and relook variceal bending. So we've done some bloods in the clinic, and these are the blood results we see. A bit anemic with HB on 9.2, white cell count a bit elevated 11, platelet count about 49,000. Renal panel not extremely remarkable, okay, with a coagulation profile with a PT that's elevated at 60 seconds, INR 1.59, and a PTT that's also slightly elevated at 50 seconds. Looking at the blood panels, we know that this patient is anemic. We know that this patient has some form of thrombocytopenia. He has got deranged PT, PTT, and INR, a bit hyponatremic, quite typical of a cirrhotic patient with a bit of liver dysfunction. How will we manage this patient before going for the variceal bleeding? Will we correct any of this? It will be interesting for the audience to perhaps type in your choices into the chat so that we kind of know what is everyone's expectation in managing this patient. I'll go back to the patient's blood management screen again in terms of blood results. Will anyone correct any of this before going for variceal bending via OGD tomorrow? Will we correct the platelet count? Will we change the PT and PTT? Will we aim for INR target of less than 1.5 before we go for surgery or procedure in this patient? So I think that's a question that's very commonly held and very commonly faced by many of us physicians managing such patients. But we have to understand that in the liver patient who has cirrhosis, they are in a new balance state. So even though platelet count, platelet activation, platelet dysfunction is occurring, there are reduced coagulation factors. There are also increased risk of thrombosis because of the lack of clearance of because of the lack of production of activated protein C, protein S, the reduction of antithrombin 3s that's circulating, the increase in factor 7 that's all pro-thrombotic. And of course, the other thing that we are not aware of commonly is the reduction in the TPA that is helping us maintain the coagulation profile of this patient. And we know that overcorrecting any of these factors in such patients actually lead up to worst outcome in such patients. And the worst case scenario is called thrombotic event of such patient. In our center, we are embarking on trials where we look at such patients coming for elective procedures, analyzing the traditional blood test with our ROTEM. And this is the ROTEM that's been done for this patient, and this is what we find on the ROTEM. To make it easier for everyone, the main interpretation of this thing shows that it's a small decrease in the amplitude in A5 in both X10 and IN10 with a relatively preserved FIB10. And this is in keeping with the thrombocytopenia picture that this patient have. But more interestingly, if you look at the clotting time of this patient, which is a surrogate marker of the PT, PTT, or INR of this patient, we find that none of this is actually significantly prolonged. In fact, if you look at the IN10, the clotting time looks shorter than expected as compared to a PT, PTT. So what does this tell us? It simply tells us that our traditional tests, looking at PT, PTT, INR, and platelet itself is insufficient for our patients, especially when we actually do not analyze whether this patient has ongoing fibrinolysis or whether the patient has a fibrinogen deficit. To summarize things, looking at this article cutout that I have here, thromboelastometry is gaining more and more significance and more role in managing patients in liver diseases, simply because we are not able to manage everything alone with our traditional coagulopathy coagulation test. Not to mention, as Lord Gollinger mentioned initially, the time from the sending off a lab test to the time the traditional blood test come back, it's actually pretty long as compared to a ROTEM diagnosis. And we know for a lot of these patients, things changes hour by hour, even day by day. Having a blood test done yesterday may not be reflective of what is happening on the day of procedure itself. And if we are to face this patient with just a lab test or wait for a new lab test at the point of time, it may lead to a lot of delays in the management of any bleeding or any coagulopathy that this patient may face. So that is one challenge and one application of ROTEM in a liver patient. So we move on next to the next case study, a trauma patient. So a typical trauma patient that we face here in Singapore is someone falling from height. Here we have an unfortunate male who was found on top of our flats walkway parapet on sunrise. Okay, it was an eyewitness fall with unknown downtime. He was found when the sun finally hit him, and they found there was someone lying there. Okay, because is on top of the usual walkway. He was hypotensive on site in the pool of blood and experienced a cardiovascular collapse in the ambulance en route to the ED. Okay, luckily he has ROSC within 5 minutes of some critical infusions. On arrival to ED, he was placed on hardboard and C-collar, cold and clammy, obvious scalp laceration and active bleeding with labored breathing with unequal chest rise. There is an obvious internally rotated right lower limb with protruding femur and tibia that's fractured. There's also a left open humerus fracture, and the pelvic binder has been placed on by our ED physician. Heart rate at the point of time is 145 with saturation of 92 on non-rebreather mask, and the BP first recorded is 60/42. How will we typically manage this patient in terms of damage control resuscitation? Will you do a massive transfusion protocol? Will you use tranexamic acid? Will we consider this patient fit for scan, or will we send this patient straight to operation? I think this is something that different institutions may have different outlook on this. But let me show you how we do it. In our institution, this is our MTP protocol, and these are our MTP packs and what it consists of. And we are running currently a hybrid MTP system where after the initiation of MTP, we actually recommend that a Rotem is being done, and then the subsequent management of this patient should be Rotem directed with application of a simple protocol that we have here to aid in decision making on what kind of blood products we need. So this patient came in. The first MTP was activated, and this was the first Rotem test that was done on this patient. Pardon me for the poor resolution, because this was obviously done in a bit of extremis and a bit of stress. Of significance, look at the FibTem. It is a straight line. There is no fibrinogen trace possible on the FibTem. This patient has probably fully depleted of fibrinogen. Look at the XTEM and look at the INTEM. The amplitude is extremely low, again suggestive of severe coagulopathy, not to mention the extremely deranged clotting time of this patient. And there was no significant correction with apotenin, meaning that there was no fibrinolysis. Despite the first MTP, this is the first what we saw. So what we do after that? We add in 8 more units of PEG cells because of the need for control of blood pressure. We give the patient 1 liter FFP, not the first choice, but probably something that we should consider at the point of time on our best form of decision at the point of time, because patient was hypovolemic and we needed some form of products to correct all the clotting derangement. We give him 6 grams of fibrinogen concentrate, hoping that we can increase the Rotem, improve the coagulation profile based on Rotem. A repeated Rotem was done on this patient, shows the improvement in fibrinogen tracing to 6 mm. Still not very good, but at least there's something now. There's significant improvement in the XTEM, INTEM in terms of amplitude, and there's a shortening of the clotting time in this patient. And of interest, if you look at this, we have a very, very rare proceeding that's happening in front of us. Active fibrinolysis with a fishtail ending, which is actually corrected by APTEM. So this patient has obviously lost a lot more blood than we have expected, and DIVC and Charlie and all these things DIVC and TACO is TIVC and damage trauma-induced coagulopathy is probably occurring at this point in time with active fibrinolysis. We are given tranexamic acid at the start. So what do we do next? We should probably top up our tranexamic acid. So with more treatment for this patient, with 2 more grams of fibrinogen concentrate, a mixture of 10 units of cryo, because by then we thought, let's mix the stuff out and try to get some whole blood-like stuff into this patient and hope that the outcome will be better. We managed to achieve a profile that's closer to normal in this patient, and we do manage to get this patient to OT and get some procedures done for all the pelvis and all the XFIX. And this patient actually, in the end, do survive the operation and all the resuscitation that was conducted, despite his extremist situation that he was found in and how he landed in our ICU. At this point in time, this patient is still alive and awake, undergoing rehab in the hospital, despite the accident being happening a few months ago. So, last but not least, let's look at the last patient that I will try to showcase before we pass on the baton to Dr. King. A vascular patient, a patient with AAA, typical history, 72-year-old elderly, diabetes, hypertension, came in suddenly, collapsed, moribund, diagnosed with a ruptured AAA in the ED via a fast scan and ultrasound, was rushed in the EOT, and this was the situation that was happening in OT. We have got our blood management team plugging out the cell saver at this point of time with assistance from everyone. Obviously, some very calm surgeons in the background. Okay, our surgeons working hard, and our level 1 in the background while everyone is trying to save this patient's life. And set up where we push in our ROTEM Sigma right next to the OT so that we can get our blood test done quickly, and a point of care results are easily available to us. The first ROTEM that we got, not too bad. Okay, after all the initial results, fibrinogen count in terms of amplitude is a bit low, but that is present, and the amplitude at the extem and intem is depressed. Not surprisingly, but not the worst case scenario. With slight increase in the clotting time in both extem and intem, and on the heptem side, we don't see much of a change because you were using this cartridge mainly because we were anticipating that this patient will be needing heparin some point of time during this whole op towards the end of surgery. Not too bad. So what do we do with this then? We noticed the FIB-10 is a bit low. We noticed that the A5 is a bit small. We postulated that if we correct the FIB-10 to 12 mm, this A5 and extem intent should correct to close to normal. And thus, we top up as per what we think you will need. We give this patient some cryoprecipitate, aiming to top out the fibrinogen part. Give him some FFP because surgeons are convinced it's woozy, even though the only derangement is slight prolongation with clotting time. But we trust the surgeons as we interact with them. For the ease of management, we give him some platelets at the same point of time to make sure that we truly will get coagulopathy managed, and then top out some bloods. And after that, this is the profile we got. Pretty decent. Almost everything is corrected. Unfortunately, by now, the op is completed. The patient actually threw a clot down into the lower limb, and heparin was actually given to this patient while we try to retrieve the clot from the lower limb. And of interest, if you look at the intem, the clotting time is significantly prolonged after the 3,000 units of heparin given to this patient, and it was corrected with heptem. So that is a role that ROTEM can actually be employed in such critical scenarios to look out for heparin effects and whether it's correctable with heparinase or even correct with reversal for heparin in some patients that are being exposed to heparin. So with that, I end my session, and so that we can quickly move on with the whole talk, and to Dr. King and Dr. Jonathan Tan. And we wait for the Q&A at the end.
Okay, thank you, Louis. I think you did a great job showing us 3 different scenarios, but also, very practical decision making. I mean, to the audience out there, it'd be great if you share with us some of your choices and what you think as well, and we can then discuss them better later on. As Louis was trying to get you to sort of discuss some of your management decision points. So thank you, Louis, for that. We'll see you at the end again. And next up, we have Dr. Christopher King. Chris is a liver and transplant anesthetist. And I always say this all the time, but I was very jealous of Chris because he had been using fibrinogen concentrates far longer than any one of us in Singapore. He had some in his back pocket. So it's always very great, Yeah. So Chris is going to take us through different scenarios, liver, and some interesting cases too. And then we'll discuss at the end as well. Thanks, Chris.
Okay, thank you. Thank you, Jonathan. I'm going to make haste and get on with presenting some cases. So I'm going to try and get through 5 cases fairly swiftly. The first one is a general surgical patient with sudden onset bleeding. The second one is an obstetric PPH, which the patient actually had a reaction to FFP, a very good reason not to be using FFP. And then 2 cases of placenta accreta, demonstrating really that maybe viscoelastic testing could have avoided using FFP, and then a trauma case. And since we've been talking about trauma, I thought I'd start off just present this one for people to think about and let the ideas percolate. So this is a 27-year-old male who suffered bilateral lower limb traumatic amputations, one above and the other below the knee, following an explosion in which 3 colleagues were killed. And so basically the question is, what would be your strategy be? Would you run an MTP with a 1-to-1-to-1 ratio, an A5 algorithm using viscoelastic testing and coagulation factor concentrates, or develop the hybrid Copenhagen approach, where it starts off with MTP and then you convert to viscoelastic testing, but do nothing, or transfuse fresh whole blood? So I'm just going to leave that hanging there, and then we'll come back to that as the last case. And I'm going to get on now with the first case, which is sudden intraoperative general surgical bleeding. So this was a 60-year-old, 50-kilo patient undergoing a laparoscopic ripples, which was converted to an open procedure because the tumor was stuck down. There was sudden uncontrolled bleeding, which took more than an hour to get control of, with very heavy blood loss, more than 7 liters, and a lot of it in the first half hour or so. It was obviously an urgent resuscitation, a bit unexpected. Lines had to be put in. The patient needed IV adrenaline. And during that, it was too fast, too much going on to do a ROTEM. So empirical tranexamic acid, fibrinogen, and red cells were given. And then the A5 algorithm was followed after that. So these are the ROTEMs done during the case. So as I said, the tranexamic acid and fibrinogen concentrate were given empirically before the first ROTEM was done. And if you look at the this first ROTEM, you can see that the clotting time is normal. The XTEM A5 is reduced, and the A5 FibTEM is reduced. And we'll just move forward to our algorithm, which we use for severe bleeding. So this is just really, I think every institution should develop their own algorithm, but basically copy what Klaus has produced. And most of the time we find that we only go down the first 2 or 3 steps of the algorithm. So we manage the hyperfibrinolysis, replace fibrinogen, and sometimes platelets. And it's very uncommon to get as far down as to needing to think about thrombin generation and give prothrombin complex concentrate. So in this case, the FibTEM was actually 8, but the patient had already been receiving fibrinogen, and the XTEM was low. So we're going to, so really the only thing that differs between these various algorithms with the FibTEM is the threshold and the target. So for our general bleeding one, we have a threshold of 9 millimeters, and then the target is 12 or more than 12. And so you choose your difference, and most of the, sorry, they'll keep flicking forward. So you can use a table, or you can do a quick approximation in an 80-kilogram adult where your target increase, you can divide it by 2, and that will give you your grams of fibrinogen. This patient was actually 50 kilos, so it's probably not appropriate to do that. You can do a calculation where you multiply that target increase by body weight and divide by 160, or you can just give fibrinogen concentrate as a standard dose of 50 milligrams per kilo, which is what we often do in pediatric cases. So going back to this case, it was decided then to give 3 grams of fibrinogen, and there was an increase in the A5 to 11, which was acceptable. The A5 XTEM was 32, and if you go back to the algorithm, it says that at that point you would then give a unit of platelets. I think it's arguable because you could actually compensate with those platelets by giving more fibrinogen, but the patient was given platelets, and by the end of the case, in fact, I think well before the end of the case, we have a very normal ROTEM. So just to talk about the platelets, is that you can, it's blanked off on my screen anyway, platelet concentrate, if you give 1 pooled platelet concentrate in an 80 kilogram patient, you can expect an increase in the XTEM by about 8 to 10 millimeters. And actually that is what has happened here. So we've gone from an A5 of 32 to 40. And you can, in extreme situations, you can start giving your platelet concentrate on the basis of XTEM A5s below 25. So the net result of all this was that the patient had 8 units of PAC cells, 1 CSP, 6 grams of thymidinogen, no FFP, was extubated the following morning and did not develop any TACO or tralling. So the second case is a PPH, which was complicated by a reaction to FFP. This was a 36-year-old woman, 87 kilos, and she was full term. And just one thing to note is that the estimated blood volume in pregnancy is very variable, but is generally going to be more than 100 mils per kilo. So considerably more than the average non-pregnant adult. So she had an epidural sited, which was working well. And then at 6 o'clock in the morning, she started pushing, and there was sort of significant PV bleeding, and a placental abruption was occurred. There was a blood loss of about 500 mils. She went for an emergency cesarean section, which was fairly straightforward, but there was a uterine atony which was unresponsive to syntocinon. She had been given tranexamic acid and some Ringer's lactate. And then when she was in the recovery area in PACU, she continued to ooze, and she started receiving blood products. And she was given FFP, and then developed a severe, significant macular rash over her chest, her neck, and her arms, which she reported as itchy. And then her blood pressure dropped to 60/30. She was tachycardic, and eventually only responded to adrenaline. Around the same time, there's a second crash cesarean section happened, which occupied that anaesthetist, but luckily the on-call obstetric anaesthetist arrived and took over, and they continued with the resuscitation and started using factor concentrates and octoplex and doing more ROTEMs. And it was rather a long delay, but eventually at 10 o'clock, she had an EUA in the OT, and it was a simple matter of suturing a couple of cervical lacerations, and the bleeding was finally stopped. So just something to say about fibrinogen levels in pregnancy is that I think many will be aware that they increase. It possibly is a compensation to thrombocytopenia, and certainly by the end of the first trimester, they've generally gone above 3 grams per litre, and then by the end of the third trimester, you're talking about fibrinogen concentrations of 4 to 5 grams per litre. And one of the significant things of this is that most FFP is obviously going to come from non-pregnant patients, so the concentration of fibrinogen is only going to be around 2 grams per litre. So giving FFP to a pregnant patient is going to actually dilute their fibrinogen. And you can see this in ROTEMs. So a healthy parturient will actually have a very large MCF on their FibTem. And if a pregnant patient has what looks like a normal FibTem in a non-pregnant patient, they are actually going to have a low FibTem. I think you all understood what I was saying then, even if I confused myself. So these were the ROTEMs, and you can see the first one was pretty dramatic and critical, and the patient's condition was pretty bad because they got a pH of 6.9 and a base deficit. You can immediately look at this and see the FibTem doesn't look right, it doesn't look normal. And not only does it not look right, it is impossible to have a FibTem which is larger than an XTEM. So the XTEM, if you saw this, as you saw from Lewis's slides earlier, this would be very worrying. Can you believe it? I don't know whether you can hear it back in. So the fibrinogen concentrate and platelets and everything started being transfused as rapidly as possible. And we started following the PPH algorithm. So as I said, the A5 algorithm using this, the only differences really are different thresholds for the FibTem. So using a threshold of 12 and a target of 16 millimeters is what is aimed for. And basically you use the same calculations as before. So you can see that there's at least there's starting to be an increase in the FibTem, and but it's still very, very low. So the A5 is only 3 millimeters, and the XTEM is still very poor. And you can also see, although these things are improving and the fibrinogen concentrate was being given all the time, this is like a test of the NDP flyby. I don't know whether you can hear me. I hope you can. So the clotting time is 92 seconds, which is prolonged. So if we look at the if we go down, we can see that a CTX-TEM is usually taken as the of 80 seconds is usually taken as the time that we start giving PCC. So this patient eventually had 1,500 units of PCC, and again, once the bleeding has stopped, the FibVoTem was pretty normal. And so the thing to also say about fibrinogen and FibTem is that with PPH, with a significant blood loss, the A5 FibTem is predictive of severe bleeding. So this is, as you can see from the algorithm, using an A5 of less than 12 is predictive of severe bleeding, and you really want to be thinking about having a fibrinogen concentrate ready to give. If it's between the A5 is 12 to 15, then you'd want to be repeating on VOTEMs and keeping a close watch on what's going on. And when it's above 15, you do not need fibrinogen replacement, although obviously you want to watch the situation. Just moving on to the placenta accreta cases, just I think this is being discussed elsewhere in this conference, but accreta is where the placenta grows too deeply into the wall of the uterus, and there's progresses from accreta to increta and percreta. And the main thing is that the placenta is going to be stuck and it's going to bleed when it's removed. So this was case 3, is a 37-year-old, many previous pregnancies and cesarean section. She had a miscarriage, and her last menstrual period was 10 weeks ago. And then when a scan was done, a hematoma was discovered on the anterior wall of the uterus, a placenta accreta. So she was planned for a surgical evacuation with possible uterine artery embolization and hysterectomy. And during the curettage under ultrasound, there was brisk bleeding. So she a Foley catheter was inserted and a balloon inflated, and she was taken to the diagnostic imaging department, where she had bilateral uterine artery embolization using gel foam and coil. She bled during this, and she received PAC cells and FFP and other fluids. But you can see in the blood results, which came obviously later, they wouldn't have come at the time of the intervention, that her fibrinogen, so she's 10 weeks, she can't really be considered as a pregnant patient anymore. So she's got a fibrinogen of 1.28, her INR is 1.2. It makes you think, well, if a viscoelastic test had been done, there would really have been no reason to give FFP based on this. The FFP is not going to give enough fibrinogen, and it's not warranted in view that there's no evidence that the thrombin generation is a concern. And the next patient was a 25-year-old having an epidural, full-term vaginal delivery, a healthy baby. She had retained placenta and a episode of hypotension, which responded to fluids. She had a bedside scan, which again revealed accreta. She was fairly stable, so the following morning she had a uterine artery angio with insertion of balloon catheters via the femorals into the uterine arteries, and then had a EUA under GA, which involved a laparotomy, and actually involved removal of the placenta via a myometral incision, which was repaired, and then a factory balloon was inserted and kept in for a couple of days. and there was a lot of blood around, but I think the actual blood loss was not as much as there, so we think it was around 400 mils. But she did have a viscoelastic test, and it quite clearly shows there was no need for her to receive any blood products. And you can see that in the lab tests that eventually came back. So these are as you see, the expected high fibrinogens in pregnancy. Disappointingly, to me, her hemoglobin was 7 on post-op day 2, but the obstetric department decided that they should still transfuse her. So now returning to this trauma case, and it's really to think what would you do with a patient like this arriving. And I must confess I never met this patient because this is a historical case. But I can honestly say I would not be here today if it were not for him, because this turns out to be my grandfather. And if we go back to World War I, he was a gunner in the Royal Artillery, somewhere in this picture. I think this is the only picture of him beforehand. And before the war, he was 190 centimeters tall. But he, as I say, he was manning a field gun in the Battle of Ypres in 1917, when they were hit by a mortar shell which killed everyone except him. This is not actually a photo of what happened. This is just one I've found. But he suffered bilateral lower limb amputations, was left for dead. And as some of you may know, that many of the wounded soldiers actually drowned in the blood and mud of the battlefields. The following day, an Australian stretcher party found him. He was still conscious, and he was taken to a casualty clearing station. And as far as I can figure, he probably never had a transfusion. And just a very brief history of fluids and transfusion in World War I, because it's quite significant to our history and what we do now, is that at the beginning of the war, the British were only using saline, but with little benefit, until they produced gum saline, which included gum acacia, which is gum arabic from the acacia tree, and which some people use in watercolor painting. Previously, they tried to use gelatin solutions made from calves' hooves, but one of the problems was they had tetanus spores in. The Canadians arrived at the beginning of the war, but they actually introduced blood transfusion, but mostly in the Canadian units, and it took some time for the British to catch on. One of the pioneers was Lawrence Bruce Robertson, but he had to transfuse from healthy soldiers rapidly to the wounded. And then it was only when Major Edward Archibald developed citrated blood that it allowed some increased time to allow transfusion. And the US turned up at the end of the war, as they sometimes do. And there was another Robertson, Oswald Hope, who introduced transfusion at casualty clearing stations and developed the first blood banking system using citrated blood stored in ice. And I think this is all probably very localized and very unlikely that my grandfather would have received anything. So this is him on the left after the war. He was not alone. There was many other amputees, and when you think that none of them had transfusions, they all survived and seem to have done quite well. Obviously, there may be survivor bias. And this is him. And one of the things was that his height used to vary depending on the prosthesis that he could afford after the war. So going back to this, what would you do? And clearly doing nothing was what actually happened. The next thing, if this was around today, is you would go for the viscoelastic test and using fractal concentrates if needed. And down the bottom, maybe if you were going to give anything, then fresh whole blood might be more worthwhile. But I think an MTP or starting off with MTP would be at the bottom of my list. And I think just looking at this various MTP activation criteria, he would have qualified for at least the activation of an MTP. And just to say, when I worked with the Red Cross in Southern Sudan, we had many landmine victims. Some of them were obviously with other kinds of infections and snakebite victims, but we had many amputees. We didn't run a blood bank, but we didn't routinely transfuse only when the hemoglobin's dropped to below 5. Do we try and transfuse patients? And this is the kind of big injury we often got. This was before digital cameras, so the only reason I took this picture is if you're astute, you will see the gastrostomy and the tracheostomy. So this was a patient with tetanus. So I think I've come to the end of my presentation. Thank you.
Thank you, Chris. I actually particularly like the history and all that at the end. It really does put a perspective and make it a lot more interesting than us just talking about factors. Yeah. So we'll collate some questions from the audience. Okay, but so I'd like to ask a few questions first. Firstly, to everybody and actually to Klaus as well. I mean, in the day and age of even defensive medicine to an extent, first do no harm, the concept of safety, and now I think it's harder to not do something than to very readily give an extra pint of blood. I think we have probably hammered that message home over the last few years, that if in doubt, give a pint of blood probably doesn't quite hold nowadays. In your earlier presentation about in the neonates and in some of the adult studies where you showed that with when you don't have ROTEM guided algorithms, the outcomes seem to be worse, particularly for thromboembolic complications. Is that the real bit about what goes wrong? And the other part to this question is, in some of those studies, Novo 7 was used as well. And we know that Novo 7, if given in a blast way, probably is going to be a bit more prothrombotic. So where do you think this safety thing is? And is it due to more Novo 7, or is it different in neonates versus adults, this safety issue?
Yeah, I think I would just start with plasma. And what is very often done still, and we even saw in the case, is to give 2 units of plasma. But even without the ROTEM, usually we can say this is not effective. And a lot of studies showed this, because that's just in an adult 5 milliliters per kilogram body weight. So the minimum amount of plasma to get a hemostatic effect is 10 to 15 milliliters per kilogram body weight.
Absolutely.
So the chances we give a sufficient amount or we don't give plasma, I think, and very often, even in Germany still, a typical dose is 2 units, 2 bags, which I think, again, is usually not sufficient. When we compare, that's the other point, PCC and Rilkeman factor 7A, I have to say also a lot of studies showed, first of all, PCC is more effective to increase thrombin generation, because the most important part is prothrombin. And there's no prothrombin and even no factor 10 in Rilkeman factor 7A. So you can shorten the clotting time, but you will not increase the area under the curve. However, we know from the randomized trials that the incidence of thromboembolic complications, in particular arterial thromboembolic complications, increases significantly. So for me, really, in particular guided by point of care, PCC is more effective, but also more safe. And that's the reason why also the European guidelines say you may use Rilkeman factor 7A if nothing else works. However, there are, of course, clear indications like acquired hemophilia, but this is a completely different story compared to a normal trauma or PPH case.
Okay. There was a question from the floor as well about post-bypass. What ROTEM tests do you recommend? And I don't know whether this is in the context of bleeding or just routine, but I know that, Klaus, you were a cardiac anesthetist in your heyday. So what did you used to do?
Yeah, I think the two most important tests is, of course, XTEM and FIBTEM. If you work with a sigma, you get always a 4-test combination. Since I mentioned that FIBTEM is the most sensitive test to thrombolysis, we need UPTEM very rarely. So it's even more important even not only in cardiovascular to see if the INTEM is prolonged. What is the reason? And for this, I need the combination INTEM and HEPTEM. And when we look more, even in trauma patients or in postpartum hemorrhage, we see some patients with a so-called endogenous heparin effect. That's when you have severe shock, we know there's damage to the endothelial cells, to the glycocalyx, and that liberates heparinoids into the circulation, which doesn't mean that we often give protamine to this patient. The main therapy is bringing patient out of shock, but it can prevent, again, to give fresh frozen plasma without any need, because if the reason for the clotting time prolongation is heparin, plasma will not work. So again, bringing patient out of shock is the most important therapy if we have this endogenous glycocalyx damage.
A practical question now to everybody. I mean, Chris, I saw in the ABGs of the patient in PACU, the obstetric bleeding patient, the patient had severe acidosis with a pH of 6.9. Question to everybody here. I mean, maybe firstly to Chris and then to Lewis. In regards to the use of PCCs and Fibriga, do you feel that they work effectively in an acidotic patient?
I would obviously we're trying to achieve these goals of normothermia and correcting acidosis. And what's the other one? But you really want
coagulopathy, temperature, and pH. Yes, yeah.
So yeah, I think you've got to be aiming. Obviously, in different scenarios, you're not going to be able to achieve all of that at the same time. But I'm sure all the factor concentrates, as much as anything, are going to be working better in a better milieu, so to say.
Yeah, I also think, of course, rewarming is very important, maybe more important in Germany than in Singapore. But acidosis is, of course, an issue. Just to correct acidosis doesn't normalize hemostasis again. But if we think about an intervention with PCC, then, of course, we have to bring the patient in more or less the optimum pH, which is even a little bit alkalotic, is even better for the enzymatic factors, but it's not good for the platelets. So to normalize the pH before I do an intervention with PCC, I think makes a lot of sense.
So Klaus, with liver transplant patients, we might quite liberally use bicarbonate. Would you think that was a good thing to do, just to make your PCC work?
Yeah, I think, again, so if we have a pH below 3.2, 3.3, the enzymatic factors are not working well, because their pH optimum is even at about 7.5. But again, this is not, the platelets don't like to have an alkalotic situation, but to bring them at least back somewhere between 7.3, 7.4, before we give enzymatic factors, I think that makes sense to optimize their effect.
Lewis, what do you think?
Yeah, I mean, I agreed on the same part. I mean, other than looking at the biochemical parameters, I like to ask my surgeon and look in the surgical field and see whether there are actually clots forming. If there are clots forming, despite whatever things I'm seeing on biochemical on the ROTEM study, then I think we are achieving some form of clot formation. But if you're talking about pH, I do agree. I do agree. I mean, it is a big blue sea and devil thing. Give bicarb or do not give bicarb. Give bicarb is just buy time. You buy time to correct the coagulopathy so that it does not swing down the vicious cycle of bleeding more and thus needing more fluids and more hypotension and more hypoperfusion. I think that's reasonable. In fact, I always advocate within an algorithm, you need to correct the pH, you need to correct the ionized calcium level, and you need a temperature up. And without any of this, you are doomed to feel in any clots form. So before you even set up the patient, it's very important your bear hugger goes on, your underbody hugger goes in, your rapid infuser with warmers go in, and everyone follows the home temperature maintenance. And the pH is extremely important to use, especially if you want to utilize PCC or even activated factor 7. You can give the most expensive stuff possible to this patient, and the pH is 6.9, and there'll be no clots being formed. You can give a huge whacking dose of factor 7, and there'll still be no clots formed. And this has borne evidence now and then, and even very recently in one of our major bleeders. You can give them activated 7, nothing forms, and the patient dies.
Yeah. So I think, yeah. So
I was wondering, sometimes when the surgeons want the OT temperature down to sort of 16 degrees or whatever, we're warming the patient's core temperature, but the temperature in the wound where the surgeon is complaining is oozing may well be the reason why they're oozing, and it's not to do with any coagulopathy. It's maybe something to look into sometime. Helicopters flying over now.
Are you staying just under where the parade is going to be, Chris? You can also watch the parade, you know.
Part of the parade.
Yeah, it has always been this conundrum, because to artificially give bicarbonate to correct the pH versus trying to improve perfusion and therefore improving your pH. Sometimes it's just gonna take too long to do that purely by optimizing hemodynamics. So I think that one important takeaway is perhaps bicarbonate. As a good friend of mine would always say, everything just give a little bit and try and get to a pH of about, as close to 7.3. Or our threshold used to be at least try to get it above 7.25. Another thing that I think a lot of times people forget is the calcium. Because for all these factors to work, we need the calcium to be above, ionized calcium at least to be close, at least 1. So that's something not to forget as well when you look at all your algorithms to put these adjuncts in as well. Okay. Let's see. There was just another question there as well. So the question here is there still a role for FFP? Given the fact that with all these factor concentrates. So another way of putting this is we have discussed this a lot, and I know in Austria it's almost obsolete, isn't it? They don't use fresh frozen plasma anymore. It's just your crystalloid with PCCs and fibrinogen. So is there still a role for FFP?
I think it doesn't disappear completely, but I think it's really for the massive transfusion patients, and most of the massive transfusion by a goal-directed therapy. But when you look at the study, the RETIC trial for trauma, as well as the cohort study from Donat Spahn, in both studies, it's 4 to 6% of the trauma population who gets fresh frozen plasma. That's the patient where we cannot avoid massive transfusion. And if I can just say, from our liver transplant ICU and liver transplant program, in the last 5 years, and this is about 700 liver transplants, that means no fresh frozen plasma except for plasma exchange. And this works quite well. And I think, again, the most important point is to stop bleeding as soon as possible. And what you mentioned, one issue is definitely the calcium level, because there's a lot of citrate in plasma. And if we give even plasma with a rapid infusion, we do a citrate anticoagulation to the patient. And if they have shock at the same time, the liver is not metabolizing the citrate anymore. And that's the reason why we have to give so much calcium to this patient. Moving to the factor concentrates, this hypocalcemia more or less disappeared because that is citrate based on the plasma transfusion.
Do you think the FFP is a source of antithrombin for ICU patients if we don't have antithrombin concentrate?
Of course, if you don't have antithrombin available, but in particular, again, also in the liver population, we saw it also contains a lot of factor VIII and von Willebrand factor, which is a very good thrombotic factor in cirrhotic patients. So again, we have to be very careful, and that might be even a difference between fibrinogen concentrate and cryoprecipitate. I would be very careful in the cirrhotic patient population because, again, a recent study from Los Angeles showed that giving a lot of plasma and cryo in the livers by increasing factor VIII and von Willebrand factor levels has a high potential of thromboembolic complications. This is much less by fibrinogen concentrate and 4-factor PCC.
Yeah, I agree on that, especially post-liver transplant. Giving FFP without guidance increase the rate of portal vein anastomosis and all these things, thrombosis tremendously. You don't really want to kill the organ just because you believe in FFP.
Yep.
Yeah, personally, I feel that the ROTEM would be a lot more useful in giving me answers in the advanced liver impaired patient versus perhaps a bleeding cardiac patient where it may be a bit more obvious what's going on just by the clinical picture, but it's the liver failure patients, where the numbers sometimes just don't add up. The numbers could be deranged, but there's no bleeding. In fact, there's thrombotic complications. So I think we've covered a lot of ground today. We have gone through the ROTEM. We've learned some new things about the ROTEM and some tests coming up. We heard about some of the new studies in the literature, reminders about current problems like the liver patients and how the traditional tests do not show what's going on. Thank you, Chris, for reminding us about the fibrinogen levels in the pregnant patients and how we should apply the algorithms differently to them as well. At the end of the day, I think the more informed decisions we make and also applying the differences in the algorithms, as Chris and Lewis both alluded to, most of the algorithms we use today all come from Klaus. So just Google and you'll see it there and pick the one that you think you can apply quickly in your clinical setting. Okay. Any last words from anybody, from all of you?
If you want to hear more about PPH, we will have the plenary session tomorrow. So that will focus on postpartum hemorrhage.
Excellent. Okay, parting words, Lewis, Chris?
Goodbye.
Okay. Let's see whether Italians win both Euro 2020 and Wimbledon. Yeah. Okay. Thank you, everyone, for joining this session and spending this Saturday evening with all of us. Thank you, Klaus, for joining us from where you are in Germany. Yeah, are you in Germany, Klaus?
Yeah, I'm actually in Germany.
Okay. Thank you, everyone.
Bye. See you tomorrow.
Bye. Have fun.